So hello, welcome to our TAVI sessions. We've got a very good ecumenical team. Professor Czerny is cardiac surgeon. I'm interventional cardiologist, and we'll be talking about TAVI, which is not entirely neuro, but it is very neuro, as you heard yesterday, because, for example, it's high risk of stroke during those procedures, and selection of patients matters a lot, and that we are going to discuss. Professor Czerny.
Thanks, Jan. So it's our pleasure to share with you very similar thoughts in these two talks. And let's start actually with current recommendations. And actually these first slides are also part of the main message of my talks. The heart team is a vital component of our daily clinical practice. And to be honest, my personal experience over the last 20 years in this profession is that you amplify your knowledge and you boost your results when you work together. And actually this is what it's all about. Why a common program is vital. So you can simulate many things, as you can see here. The Heart Navigator is an excellent tool to simulate how your valve will look like in your individual aortic route. But what the heart simulator cannot simulate is actually the tactile feedback of the local calcium distribution, and it cannot simulate how the calcium will behave after deployment of your valve. And this is why interaction between specialties is so important, because what we started to do is to have our cardiologists in the operating room touch the disease, touch mitral leaflets, touch aortic leaflets, touch calcified iliacs, because the feedback between imaging and tactile feedback will change your mind when dealing with this complex cohort of patients. And this is also how we act together in the operating room, because this is an example of a borderline case where we had lots of discussions, said, well, both options are available, let's go for a TAVI first approach, but we were unclear how the bars of calcium will behave during valve deployment. And so this is something we do not do on a regular basis, which is predilation, but this was not for paving the way for the prosthesis, but to get an idea how the calcium will behave after valve implantation, so to say, simulate valve implantation. And as you can see, this bar of calcium moves very, very close to the left ostium. So we said, well, let's go back. The setting is very clear. The patient is draped, is fully informed of a potential elective switch. If the first approach would be unsuccessful, wouldn't be ideal. And so we just removed the sheath, went for classical surgery, replaced the valve, nothing happened, everybody's happy. And this is what it should be all about. Anticipate what can happen, explore the options, and be prepared for a change of strategy if your initial strategy will not perform the way you expect that. So this is a case of bicuspid aortopathy. I just want to share with you. This is actually a surgery first case, yeah, because it's a combination of aortic valve stenosis here, a CVAS type 1 with a fusion between left and right, a lot of asymmetric calcium distribution, ascending aneurysm, coronary artery disease. So it's not so much about discussing the option to go for, but it's about seeing the morphology in the aortic root, because this patient had an extension of the calcification over the aortomitral continuity down to the anterior mitral leaflet, and this is actually what I want to show. You can see it now here. So the aortic valve is removed. We do now have the anterior mitral leaflet in our hands, and you can easily understand how annular rupture can happen when you see these kind of pictures when you inflate a valve in such a kind of scenario where you have calcification beyond the aortic valve annulus. And this is also, if you have seen such a kind of scenario, it will shape your, it will change your decision-making tree for future cases. So heart valve clinics, in our opinion, are the way to go. It's so much about preoperative imaging to understand the disease process, to have all, to explore all details. It's about the procedures available. It's about collaborative services, standardized processes, and also data review, especially of the ones who had a different outcome than expected. And actually, this is, in our opinion, how such a valve, or this is just a portfolio. A valve clinic has to be able to provide service to patients. You have to have everything under one umbrella. You have to be able to have a very robust program for valve sparing aortic root surgery. You have to have all kind of biological and mechanical prosthesis in your hands, because all of them have pros and all of them have cons. It's with regard to rapid deployment valves, which are very attractive, especially in an environment where we have a lot of discussions about patient prosthesis mismatch and different gradients between surgical valves and TAVI valves. And of course, you have to be able to provide the entire spectrum of TAVI valves, because all of them provide you with procedural details which are beneficial in certain clinical scenarios. And one of them we will discuss here. This is a case of a patient. This is just with regard to our program. So we have a one-to-one distribution of surgical valves, surgical valve implantation and TAVI valve implantation, about 500 each. We have a distribution of about 1 to 10 with regard to transfemoral and transapical, and we do use all currently available valves, catheter base as well as surgical, and these are the individuals involved in our program, and this is the case. I would like to share with you a classical case all of you will be confronted with in daily clinical practice. A 76-year-old male having had CABG a few years ago, low flow, low gradient aortic stenosis, and quite extensive tortuous excess vessels. So here a short glance with a tricuspid aortic valve, quite symmetric calcium distribution, not extending the annular plane, but severe thoracoabdominal kinking as well as iliac kinking. So in other words, by transfemoral approach, the remaining probability of having challenges while deploying the valve, because you lose a lot of a lot of pushability through access, is pretty high, as can be seen here. And this is actually the options you have in these patients. Transfemoral, these are these kind of patients. You can use each and every modality available: transfemoral, transapical, any alternative access site. Surgical AVR, of course, conservative is not an option because of symptoms and the extent of disease. But, and then if you would go, for instance, for a TAVI approach in this kind of setting, the question is between balloon and self-expandable. In this kind of case, we went for self-expandable because of the low distance to the coronaries, and the transfemoral approach, despite borderline conditions you have just seen. And this is what sometimes happens. It takes some time that the prosthesis is in place. You're very happy that the prosthesis is in place, but the thing doesn't open up. Because with these severe tortuosities, you're not able to manipulate the way you want to. But as we aim to be prepared for each and every scenario, the thing is the patient is draped, has informed consent for any kind of conversion, be it to transapical, be it to or to a classical surgical approach. So the only question you have to pose yourself, how to escalate the situation, by transapical TAVI or by classical surgery. We decided for transapical TAVI. What I mentioned is that the distance to the coronaries was low, so the ideal valve to deal with low coronary distances is the Symetis valve. Now Boston Scientific, why is that? Because you have markers marking the struts of the valve, and you can have an anatomical orientation within the aortic root that the native commissures exactly overlap with the struts of the valve. And this is how these procedures are performed. We are locating exactly, and this is an important detail, you have to be exactly aware where the apex is located, because these procedures fail and win with the cannulation site. And so a submammary incision is made, the pericardium is opened, and the cannulation stitches at the apex are placed. And then we routinely implant this kind of valve in a 3-bulby view because it gives you the best anatomical orientation of where you are. And then by rotating the loaded valve under fluoroscopy, you can be very clear where the commissure between the right, or the exact location of the commissure between the right and the non-coronary sinus is located, which gives you a perfect anatomical orientation of the valve during deployment. And as this valve works by capturing the leaflets, this is the second detail which really is beneficial in patients with very low coronary distances, and we are using this valve additionally in patients with failed homografts where you have coronary distances down to 2 or 3 millimeters, and this really works well, provided, here you can see the loaded valve, provided that you really have an exact anatomical orientation of the native commissures to the struts of the valve, as can be seen here. And by slight, the crown opens up, and then by slight retraction, you reach the final positioning. This is also what you can do from transfemoral, but the thing is that by a transfemoral approach, you're not able to have this anatomical correction, which would be nice to have, but currently is not available. And so here you can see this retraction move you do, and then the second step of the deployment is initiated. This can be seen in a second. And you have all the time in the world to correct, because this valve doesn't need rapid pacing during deployment. And now if you're happy with your orientation, your positioning, you release the basal component, and then we are set. So do never underestimate tortuosities. Know where to stop if things develop different than expected. And in case of doubt regarding excess, choose an alternative access site. A final word about risk stratification. I'm pretty convinced that currently our discussion when TAVI, when surgery goes in the wrong direction, because we're just talking about patient-specific risk factors. We are not talking about what we should do, and this actually is risk according to morphology of the aortic valve, of the aortic root, of excess vessels, because this is what it's all about. So there are many patients with low morphological risk, and to be honest, my personal opinion is they shall undergo TAVI because it's an excellent treatment modality, and the probability of success in low to moderate calcification, symmetrical calcification, large distance to coronary ostia, and large excess vessels is excellent. But there is an intermediate group with extended risk criteria, moderate to severe asymmetric calcification, borderline distances, kinking, challenging excess vessels, and they will have trade-off results. And there are the one with very high morphological risk for TAVI, with severe asymmetric calcification, extension of the calcification beyond the aortic annulus, over the aortomitral continuity, and reaching the anterior mitral leaflet, and these are the ones who have very high risk for TAVI. And so I think these are the reasons why young patients can undergo TAVI, but even patients in the mid-80s have to go undergo surgery because their risk, their outcome, their morphological risk is high, and their outcome with TAVI will be unsatisfactory. This is what we're doing today. We are just stratifying according to patient risk factors, and this is what we should do. It should be a discussion about morphological risk factors. I think pretty convinced this is what the future will head to, and which the next round of guidelines in 2022 will also address. So summarizing, surgery against intervention is a very two-dimensional view we should not follow. The four-dimensional view is that a group of physicians showing, providing the entire range of treatment options, treat the patients, the entire group of patients being referred, and the interaction between specialities, of course, will further increase. Think about the mitral, think about the tricuspid, and combining efforts efforts between specialities, and this is my personal experience over 20 years, is mutually inspiring and amplifies knowledge and skills, and the heart team fails together and even better wins together. Thank you. We will have both talks and then have the discussion afterwards.
Okay, thank you very much. So, my presentation. Can I have my talk, please? Okay, so as I said, I'm a cardiologist in my disclosure, so I implant most of those TAVI valves and teach how to implant them. We are ESC meeting, so it's very important to mention actually there's new, not that new, 2017 guidelines on valve management and team management. Specifically, it's embedded there that should be heart team or valve team who should look after patients with, as you see here, after the valve, aortic stenosis specifically because of complexity of such a patient. What does it consist of? Is a multidisciplinary outpatient clinic, and patients should have a story from all specialties involved, meetings where they all sit together looking at technical aspects, as we heard, anatomy, etc. We've got some multimodal imager, mainly echo, CT, people being part of it, and we've got all comprehensive aftercare, as well as what we learn from surgeon, our outcome data should be known. So this is a composition of such a nice team, quite a few specialists, apart from usual doctors, there's also valve coordinator, important role, and also physician for elderly. We learn that sometimes even if we can do intervention, it's not in patient best interest, and we use such a geriatrician like gatekeeper. There might be individual variations. People are not made equal. In some team there is a strong, excellent surgeon, so may sway towards surgery, and vice versa. There are individual countries, reimbursement policies, etc. I mentioned in UK, TAVI procedure is relatively less expensive, hospital bed is expensive, could be probably opposite in many or most countries in the world. We are quite blessed with current evidence which shows that TAVI definitely works where surgery is not possible, but we got also this middle area where either of them is possible, and we got some evidence for it. So multidisciplinary team using this evidence, but also their best skill in the group to decide what's the best for the patient. Bit like thrombolysis and stroke or mechanical thrombectomy, we are very blessed. That's actually all class 1. So contrary to elective coronary angioplasty, after 50 years, we are still not sure how we affect patient outcome. Evidence for aortic stenosis for either of interventions well established, and even some borderline difficult anatomies or groups with some additional comorbidities. Again, this is all with those contemporary guidelines. So how we do with that middle? We've got evidence, as I said, it all started with high-risk and inoperable patients, original pivotal trials, partner and core valve, which showed that TAVI is superior to doing nothing, obviously. You probably know that 5 years outcome of untreated aortic stenosis is worse than lung cancer, so mortality is higher. Doesn't send same message if you say the word cancer, but that's what we learned from those early trials. We know it's also is as good as we think, and maybe better for those so-called moderate risk. And currently we got few trials looking at the low-risk patients. Again, I would like to show team decision-making in a couple cases, which this is typically in my place if patient's elderly, so because of mobilization, rehabilitation, etc. So there's one factor which in surgical group is taken as an additional risk. So we look into this patient who then have all assessment to confirm severity of stenosis, as you see on echo, undoubtedly severe. Then what's very important is size. So we've got now multimodality imaging. This is quite very nice, modern Siemens echo software. So we can actually see it is gold standard, but we can get a very good picture which will tell you about size, be it diameter, perimeter, area, depends which valve we are going to use. So we've got a variety of options, which is then compounded by complete CT measurement, which tells all those subtle anatomical features, quantitatively, qualitatively, how big is the annulus, sinus, where are the coronary arteries, where is the calcium, what are the affection of adjacent valves, and also tells about access. So in this case, again, as team a discussion, this loosely femoral arteries, why caliber is good, are very, very tortuous. Our surgeon is skilled in subclavian access, which he favors. We do some additional measurement with simulation software, so you can actually put valve into simulator, or you can simulate different anatomies and tell you some additional points One is sizing, one is how much leak you get on the depth where valve is implanted, but also you see those purple points on the right side. It will tell you how much pressure points, because one of contentious issue is pacemaker requirement after TAVI procedure. So we can actually, some early data suggested if you really go into millimeter precision, you can reduce all those complications. So here the plan was to use the subclavian access for, this is core valve, evolute, which is self-expanding valve, which is then implanted in standard fashion, and at the end you see very satisfactory result or no regurgitation. Such a patient goes home after 48 hours and effect is very nice. This is different situation, or not quite different, also quite elderly gentleman, present heart failure, he's got problem is kidney, he's got arthritis. Again, it's very frequently that mobility is one thing which sways in the MDT meeting debate towards TAVI in our group with laboratory. Valve again confirmed severe. There is some coronary artery disease. You see occluded left antrodescending artery. I mentioned in a moment we are not quite sure what to do with these concomitant diseases, and evidence is lacking how to treat and when. We see very good femoral access. So in this case, again, we do all our scoring, we do our measurements, and we decided implant transfemorally this time because size is good. It's not extremely tortuous on the right side. I used this valve you've seen earlier, this time in transfemoral fashion. The CMET is accurate valve, which, yeah, it's kind of easy, simple implantation, good anatomy. Again, very good result, no regurgitation, local anesthesia, rapid mobilization. So you do those, but you need to be prepared as a whole team, and we learn in the process. This is just one older slide from my presentation, TCT, and you see the table that actually we learn, and outcome is better in 3 time periods. Why is that? Because we learn how to do those valves. We also get much better engineering, what they give us, more forgiving valves, but thirdly, we also learn when not to do procedure, because some patients are really futile, they are too fragile. Hence, on that clinical side, the geriatric or holistic physician is important. Nevertheless, as you see, all practice is green, and theory is gray, is moving ahead of guidelines. So we have a patient lower risk than what evidence is for. Nevertheless, there are some questions before we run it for free completely everywhere. We still need to know something about valve durability, because while surgery is around for decades, this is only 10 years plus, so it's really short. The threshold risks are still evolving. We need to learn whether one valve is better over another, even though we logically use one over another in certain anatomies. Question whether the team should survive, but there are already some people, we don't need surgeon, etc. I think it's wrong. Again, we got this analogy with stroke, neurosurgery, etc. There are some evolving indication, and also how training. We got this battle here about training in stroke. It's the same, who will be doing, how much training is required. And again, it doesn't matter which specialty, you just need to learn and pass all those and have an audited outcome, that's it. There's still be off-label indication. Of those is mainly aortic regurgitation, because valve needs some calcium to land. So we'll see what we see. We don't know if there's concomitant coronary artery disease. If you cannot do surgery, which you should do preferably, is it okay to do both procedures same time? There's no study at the moment close to be finished. Nevertheless, it seems to be there are some risks. Why it's some logical point for it, why you should do both. So far, studies show that you might actually get more complication from it without no certain knowledge about long-term outcomes. So we need to learn more about that. You got more access, procedures prolonged, etc., etc. Nevertheless, again, TAVI is marching on. There is plethora of those low-risk trial for all comers, patients with less than severe aortic stenosis, impaired LV function, asymptomatic patients. Demography is everyone will get aortic stenosis, 80+ populations getting older. This is first study which is kind of initial reassurance, because again, one argument before we lower down, how is durability, how is performance in long term? This is Nordic study notion, which is all risk patient, all comers, and it was still a relatively obsolete valve designed by today's standard. Nevertheless, this our 6-year follow-up, it seems to be that even that group is matching outcome of surgery. So without being definite, it's reassuring so far. We also see some very favorable anatomical features. We are probably getting bigger orifices as we valve often place supraannulary, which means also less gradient, because it's tricky for surgeons sometimes to cut calcium in the annulus. So it might be in some technology they just can make valve bigger, which means time until restenosis will just be longer. That's simple logic. Nevertheless, all primary endpoints seems to be met. So while we are not saying that TAVI can have a some superior, or at least we know there's no clear indicators to be inferior in longer-term performance. And in fact, in some aspect, with so-called structural deterioration in the trial, there seems still less structural deterioration, which means stenosis inside surgical valve or leak inside the valve. I'm not talking about non-structural, which comes to skill of the team, positioning, etc. So again, so far reassuring. So you can say that hemodynamic is maintained, failure is low, and we don't seem to have more infection, for example, which is important, neither thrombosis. There are still some anatomies which probably forever, as Professor Czerny mentioned, will prefer surgery. Some anatomies TAVI, and as I said, you can learn hard way only in the room. I have a few of them here. Transfemoral access, definitely favorable. Non-transfemoral needs very good, experienced, skilled surgeon. There are many of them. Not all patients can have all those non-transfemoral. Some is sometimes only apical, sometimes only aortic. So again, you need the skill for those alternative procedures, or you go back to surgery. On the other side, you got various non-cardiac problems, chest deformity, etc., which favor TAVI over surgery. Concomitant valve disease, despite all effort and enthusiasm, we don't have any routine clinically viable mitral or tricuspid device as yet. It's ongoing research for us. 10, 15 years is still not developed. So if this additional valve and solution is possible, it is surgical. Nevertheless, for pure TAVI, for pure aortic stenosis, it seems to be TAVI becoming dominant one. But then what's then left for surgeon? There's still plenty of them, the young congenital surgical coronary artery disease, if you're outside range, pure aortic regurgitation. And TAVI, though, is becoming first choice because we got this reassurance, as I tried to mention, we improve our precision planning, precision performance, and variety of designs. Same time, surgeons are needed more than ever. A cardiac surgeon role in leadership of such a meeting is more important than ever. As a team member, implanter, as a quality control gatekeeper, someone who does those combined procedures for which at the moment we just don't have any device. There is still a lot of patients who are young, who had a metallic valve. There will be always some anatomical limitation of TAVI. We need them, and we need them badly and quickly if it's bailout, because if TAVI goes wrong, should be rare, it goes horribly wrong. So you pray surgery be next to you. There are some failed surgical valve that only be treated with second surgery because valve is too small, and we need him for all those alternative accesses. So we look after our surgeons better than ever before, but we are a great team together. Thank you very much.